This is the radiographic positioning portion for the sternum. Our objectives, we're going to talk about the technical considerations, the procedural steps for essential projections, and the anatomy best demonstrated on each essential projection for the sternum specifically. So this is an overview of the projections and positions that we will be discussing today. PA oblique sternum, RAO position, PA oblique projection, or the Moore method, a lateral sternum, and the dorsal decubitus position for lateral. So the sternum is a little bit more difficult to radiograph. It has denser thoracic structures, both bony and soft. With the location of the sternum, it's directly anterior to the thoracic spine. So an AP or PA projection provides little or useful diagnostic information. To separate the vertebra and the sternum, it is necessary to either rotate the body to a prone position or angle the central ray medially. The exact degree will depend on the depth of the chest, with deep chest requiring less angulation than a shallow chest. Few problems are generally involved with obtaining a lateral position projection. The angulation of the body or the central ray to project the sternum over the right of the thoracic vertebra clears the sternum of the vertebral bodies, but it superimposes it over the posterior ribs and the lung markings. If the sternum is projected to the left of the thoracic vertebra, it is also projected over the heart and other mediastinal structures. The superimposition of the homogeneous density of the heart can be used to an advantage. The motion of shallow breathing is used to eliminate the lung markings. If motion is desired, the exposure time should be long enough to cover several phases of shallow respiration. The MA must be relatively low to achieve the desired MAS. And for your female patients who have large pendulous breasts, the breast should be drawn to the side to side, or down below. All right, here we have an example of the PA oblique sternum, the LAO position on the left image here. And on the right image, we have a PA oblique sternum, RAO position. All right, so we can see the shadow of the of the body, Your manubrium is up here, and your xiphoid process is down here. Same on this image, we have your manubrium up top, the body of the sternum here, and the xiphoid process here. All right, here we have, on the left, this is a patient with suspended respiration, or they're holding their breath. And on the right image, this is shallow breathing during an extended exposure. So you can see that on using the shallow breathing technique and a longer MAS, we can obtain a better image, a more clear, more defined image versus a patient holding their breath. All right, so for your PA oblique projection, your RAO position, your patient is going to be either upright or recumbent, laying prone. You will rotate your patient 15 to 20 degrees for an RAO position. 30-inch SID. The top of your IR or your collimated field is 1 to 1/2 inch above your jugular notch. The CR is going to be perpendicular and it's going to enter the elevated side of the posterior thorax about 1 inch lateral to the MSP at the level of T7. You're going to collimate to a 10 by 12 inch field. Of course, provide the gonadal shielding as applicable. And you're going to instruct your patient to take slow, shallow breaths during exposure or a suspended respiration after they exhale. All right, so your central ray is going to be perpendicular to the IR. It will enter the elevated side at the level of T7, 1 inch to the mid-sagittal plane. There should be clearly demonstrated the entire sternum jugular notch to the tip of the xiphoid process. You should have reasonably good visibility of the sternum through the thorax, including the blurred pulmonary markings when using a breathing technique. The thorax should be minimally rotated, demonstrated by no superimposition of the vertebral column and minimally oblique vertebra to prevent excessive rotation of the sternum. The lateral portion of the manubrium and SC joint should be free of superimposition over the vertebra, and the sternum should be projected over the heart. All right, for the Moore method for patients who are not able to rotate, your IR is going to be crosswise. The x-ray tube is on the patient's right, and you're going to angle so that your CR is 25 degrees towards the patient. You're going to center your IR to your CR. Place the patient at the side of the table in front of and center to the table grid. So the patient is going to bend at the waist and rest the thorax on the table so they will be completely prone. This centers the sternum to the IR without placing as much weight on the thorax as a prone position to increase patient comfort. The arms should be above the head, resting on the table. This moves the arms out of the anatomy of interest. Your CR is going to be angled 25 degrees towards the mid-sagittal plane. If positioning is accurate, your CR should enter at the T7 level and 2 inches to the right of the spine. What this does is centers your anatomy of interest, and you want to make sure you collimate to your anatomy. This will also project the sternum into the lung field for greater contrast. Make sure you collimate to a 10 by 12 inch field. Provide gonadal shielding when necessary. And you're going to instruct your patient to breathe shallowly during the exposure. So you can see this patient is bent over the table. That way it's not putting as much pressure on their chest. Your CR is angled 25 degrees. It's entering on the right side of the MSP at the level of T7. All right. So in our top image here, we have a lateral projection. This is the left position, and the patient is upright. Then we have a lateral projection, right position, and patient is recumbent. And here we have a lateral projection, right position, dorsal decubitus. All right, so your positioning, your patient's going to be upright or in a recumbent lateral position or dorsal decubitus, depending on your patient condition and what they're able to do. SID is going to be at 72 inches for your lateral. Arms are going to be overhead in recumbent positions, or if the patient is upright, The arms are going to be behind the back. Shoulders are going to be rotated posteriorly. Your CR is going to be perpendicular. It's going to enter at the lateral border of the mid-sternum. Your field size is going to be 10 by 12 inch. Gonadal shielding as needed, and the patient is going to suspend respiration after a deep inhalation. So they are going to take in a breath and hold it. All right, so your central ray should be perpendicular to your IR, entering at the lateral border of the mid-sternum. The structures shown are in the lateral image, it should show the entire length of the sternum, superimposed sternoclavicular joints, and medial ends of the clavicle. For your evaluation criteria, you should be able to see the sternum in its entirety, your manubrium free of superimposition by soft tissue of the shoulders, sternum free of superimposition by the ribs, and the lower portion of the sternum should be unobscured by the breast of a female patient. So make sure you are collimating properly and you are able to see some bony trabecular details in surrounding soft tissues. All right, let's review. Which of the following criteria is used to evaluate a PA oblique projection of the sternum? A. Sternum projected just free of superimposition from bony thorax. B. Manubrium free of superimposition by the soft tissue of the shoulders. C. An open SC joint space. Or D. Approximately twice as much distance between the bony thorax and the lateral border of the sternum on the affected side as is present on the unaffected side, the most inferior port. Oh, and that is a typo. I will need to fix that. So I'll give you a minute to think about it and disregard this portion right here. All right, so the correct answer, the sternum should be projected just free of superimposition from the bony thorax. This is an evaluation criteria to evaluate a PA oblique of the sternum. All right, question 2. What projection and anatomy are demonstrated in this image? A. AP oblique projection, SC joint. B. PA oblique projection, sternum. C. AP oblique projection, sternum. Or D. PA oblique projection, SC joint. And this would be B. PA oblique projection for the sternum. All right, that concludes our lesson on anatomy and projections for the sternum, positioning for the sternum. So I do have a handout here, and for homework, you all will fill in the anatomy, identify all of the anatomy structures in both the graphic and the radiographic image. So there's 3 in total that you will need to do. And for the next portion, we are going to move into our practicing our positioning, which you just learned in the lab. And for that, I have included a quick reference guide for you. So this includes some graphics that show detailed of all of the anatomy for the sternum and for the bony thorax. Here's the sternum. This also includes a technique chart for quick reference, and also the positioning for your PA oblique sternum, the RAO position. And this art here is an axial view from the patient's feet upward. Okay, so their left side is going to be rotated up away from the table. All right, and then we have your lateral sternum. So your CR is going to enter at the lateral border of the mid-sternum, of the body of the sternum. And then we have the Moore method, or the recumbent position for the lateral. And here is the dorsal decubitus position. So when you're practicing, make sure that your patient looks similar to the pictures here, and also make sure that you review where your CR is entering, and make sure that you are collimating to the anatomy of interest. So what we're going to do for labs today is we are actually going to do a collaborative learning activity. For this assignment, I want you to be in groups of 3 or 4. You're going to work together to film yourselves and then edit the video of each one of you demonstrating and verbally answering questions. You can use your cell phone or other recording devices that you may have, a camera. You're going to use video editing software to combine all of the group's efforts into one video. So in your video, I want you to include your techniques, identify the location of the central ray, talk about your anatomical landmarks such as the jugular notch and the xiphoid process. You are going to demonstrate as if you were a technologist with a patient. So get into your role, really practice each position, talk to the patient, describe the process, describe your thought process, and what you're doing through the entire process for positioning. Then you're going to explain what criteria you would use to hypothetically evaluate your image. You're going to describe what you're going to change if you have a trauma patient, or that's on a backboard, or if the patient has their arm strapped down, or any other situations that you think you might encounter. After you submit, your video will be reviewed by other groups within the class as well as myself, and we will follow a rubric for scoring. So key things to remember: make sure you talk your classmates through everything, talk to your patients, inform them of what's going on, let everyone else know what you're doing, what your thought process is. Make sure you identify your anatomical landmarks, your central ray, how much you would collimate, what technique you would use, and don't forget to include your evaluation criteria, hypothetically, what you would be looking for on your image to ensure that it is a diagnostic image. And if you have any questions, let me know. All right. Good luck.